So, good evening, friends, and welcome back to the Thursday evening teaching session brought to you from LTMMC San Hospital, Mumbai. We thank the authorities at San Hospital for allowing us to conduct these classes here, and we thank Aristo Pharmaceuticals for a scientific grant which facilitates the live webcast of these classes. So we start with our cases today. We have two cases. The first one is being presented by Dr. Sagar Deep from Sion Hospital.
Good evening, sir. I'll be presenting today's case. So the history goes like 7-month-old boy, fourth by birth order, born of non-consanguineous marriage, hailing from UP and resident of Nala Supara, Muslim by religion, brought by and informed by mother, reliable, with the complaint of intermittent tightening of limbs since the age of 2 months. Child has significant birth history, so I would like to start from there. In the antenatal history, the age of conception was 38 years. There is no history of any smoking, alcohol intake, radiation exposure, or unknown drugs. No history of infertility, no history of abortion or neonatal deaths. It was a registered pregnancy. Mother had anemia, and so she required iron injections during second trimester, and she was not very compliant with the iron and folic acid supplements. She is immunized with the 2 doses of tetanus toxoid. Ultrasound was done twice, one in the first and another in the second trimester, told to be normal. No history of fever with rash, no history of any hypertension, diabetes mellitus, or thyroid dysfunction. History of leaking per vaginum is present since 24 hours. It was not associated with fever, and it was non-foul smelling discharge. It was a full-term pregnancy, delivered vaginally, cried immediately after birth. Child weighed 2.8 kg and history of NICU stay is present. There is also history of prolonged first stage of labor. According to the informant, she required approximately 24 hours between onset of labor pain and delivery of the child. However, child cried immediately after birth and no resuscitation was required post-delivery. Child was started on breast milk 1 hour after birth and discharged on the same day of delivery. Postnatal history on day of life 3, child was admitted in NICU in view of neonatal jaundice. So after 24 hours of birth, mother noticed that the child was lethargic, would prefer to sleep most of the time, was not sucking breast milk well, and he had developed jaundice on day of life 3. Was admitted in NICU for 4 days, received phototherapy, no history of any exchange transfusion, no history of neonatal seizure, and no hearing tests were done. After discharge, child was slightly better. However, he remained to be less interactive, less active, would prefer to sleep most of the time, but was able to suck breast milk. He never looked at face when spoken to or at any toy, did not smile back, did not make much sounds as well, but he used to get startled on some loud noise, but never looked at the side of the noise. At around 2 months of age, one fine day, mother noticed that the child had paroxysmal event in the form of tightening and stiffness of the whole body, including bilateral upper limb and lower limb, associated with arching of the back lasting for 15 to 20 minutes. Such episodes occurred 5 to 6 times per day, subsided on their own, and these events were preceded by excessive inconsolable cry. There was no uprolling of eyeball, deviation of the angle of mouth, frothing, or any increase in the breathing rate, and they never occurred in sleep. Over the past few days, child used to cry excessively, followed by tightening of all 4 limbs, and the frequency of such events increased. The child also does intermittent protrusion of the tongue on his own. There is no history of any drooling of saliva, difficulty in changing diapers. The child was started on bottle feeding since day 10 of life because mother had low milk output, according to her, and he was able to suck breast milk. For the above complaint, child was taken to a local doctor in UP, wherein they were advised MRI brain and was put on some supplements. Since past 25 days, child had new onset paroxysmal event in the form of sudden forward drooping of the head, along with closed fist, lasting for few seconds, occurring multiple times a day. There is no history of fever. Family history of epilepsy is present. Child's maternal aunt is a known case of epilepsy on medication. Thereafter, they have come to Mumbai from UP and consulted Wadia Hospital, wherein parents were told child has some neurological disease affecting posture and advised MRI brain and put him on some medications. Over the past 6 months, now child is 7 months old, child did not achieve any milestone, no head control, hand regard, social, smile, cooing. He intermittently opens his hand. The child would simply lie down on bed with intermittent tightening of the limbs. No history of contractures, recurrent respiratory tract infections. However, the child has not gained significant weight over the period of 6 months. Parents have brought the child to this hospital in view of financial constraint. No past history of any admission. Child is immunized till 6 weeks. Developmentally wise, there is global developmental delay. In the gross motor milestone, child momentarily lifts the head in the plane of the body. There is no head control. Fine motor, only hand opening is present. There is no cooing, but startle is present. And the child doesn't look when spoken to. There is no fixing and following to light. Dietary history, child was initially exclusively breastfed till 7 to 8 days of life and then started on top feeds, 2 scoops of formula milk, formula powder in 30 ml of water, 7 to 8 times per day via bottle. Currently, child is being fed with diluted cow's milk, 500 ml per day in divided fractions via bottle. So by 24 hours recall method, the observed calories is 300 while the expected is 830. And the protein intake is 12 gram per day while expected is 14 gram per day. The child has got 3 other siblings. The third sibling has got intellectual disability with developmental delay, but there is no history of seizure. 7 months is the proband. They belong to upper lower class according to modified Kuppuswamy's classification.
Okay, so age at conception 38 years. So what significance does it have for you? What are your thought process? Everything that you take in the history should have a meaning for you, no? So why do you ask the age? And why mention 38 years?
So with increasing age, the chances of any chromosomal abnormality or any neurological disease, it increases.
Good. Anything else? So would it make a difference if 38 years first pregnancy or 38 years fourth pregnancy? Would that make a difference?
I think age is one factor, but the maternal health or maternal problems are another factor. If there's a multiple pregnancies, okay, likely the child may not have kept the health status as well as the first time. So it's not only the age per se. So multiple pregnancies. Next is how frequent multiple pregnancies. Is there a time in between to recover health, or there is no time at all? So many small little things are important. And that puts us to say that, has the problem been of a genetic origin because of the age, or has the problem been due to maternal ill health, which is hidden? She has no complaint. When you ask her, do you have fever, do you have hypertension, do you have... No, I have nothing. But she has everything. Because the multiple pregnancy, poor nutrition is a multi-system disorder, where the symptoms are hidden. Liver is not working well, anemia is there, okay, heart is not working well, systems are affected, and therefore we want to know all those details when you said 38 weeks. Okay, we are just trying to build up. That doesn't tell us what kind of problem we are going to face, but that tells you that there is going to be a problem. Imagine this child came for a first ultrasound somewhere. At that time the person would have said, I think we are in trouble. You come better at a better institution to monitor, to deliver. maybe you have a problem at birth, that could have saved some problem, not necessarily.
So point is that whatever little bit that you take in history, everything must have a meaning, and you should start thinking, okay, 38, so this, and all these questions. Because all along I was trying to find out, till you came to the family history, whether 38 years was the first pregnancy or the multiple pregnancy. It's only when you told us that this is the fourth child that I realized. And that had an importance in my mind.
Again, if it's a first pregnancy at that age, why was that the first pregnancy? Was the problem with her husband, whatever? It's not easy for her to answer that. But did you do anything for it? Did the doctor say anything? Now, all that would say whether who was at fault for that late conception. It could be natural. But we start inquiring about it. See, these are very delicate questions where you don't want to set up a kind of a wrong interpretation. Oh, my doctor said it could be your husband, not you. Okay? Or vice versa. So, we should be very careful to say, no, sometimes there is a naturally no conception. Sometimes there is some illness, maybe in the family, maybe with the husband, maybe the mother. That means we give her all options. Don't blame anybody particularly.
Okay, then mother had anemia and required iron injections during second trimester. So what kind of injectable iron would she have received? What kind of injectable iron do we use, if at all? When do we use?
Iron sucrose.
IM or IV? IV. So we have stopped using IM iron almost. It was used a few years back maybe, but not now. But when do you use IV iron?
Third trimester. To
So because it's nearing the delivery process, so we need to cope up the acute stress.
So there's nothing specific that you can't use in second or you can use only in third. But the point is that if you are close to delivery and you feel that there's not enough time, she's not going to cooperate with oral, etc., then you may choose. But the point is, use IV as a last resort, not at the drop of a hat. So in the second trimester, actually you should have enough time and scope to try and give oral only. Here you've written that she couldn't tolerate or something. So that's okay.
Does IV iron push up the hemoglobin fast? Then what's the advantage?
So it is same as oral, but people who cannot tolerate iron supplements has some gastric complaints. In that, those people we prefer IV.
क्या कुछ तुम किधर से डाल सकते?
also the compliance, when compliance is an issue, we are not sure if the patient will regularly take the medication orally, we go for an IV.
And in case there is any GI malabsorption of iron, then we can go for parenteral iron or a severe anemia.
Very good. So it's only when you don't want to leave a compliance on the part of the patient that you do it. Is iron safe, IV? It's very safe now. Earlier it was not safe. The newer molecules are fairly safe, no reaction, but still there is no great indication either. But gone are the days when iron could be even dangerous, IV iron. Today the molecules are available which are as safe, but not much indicated.
Okay. Baby was discharged on the same day of
There was
delivery.
something in the last line, earlier slide. Leaking per vagina since 24 hours. What does that mean?
So this could suggest like maternal chorioamnionitis
Okay.
with history of fever, and if foul-smelling discharge is present, then this could suggest a chorioamnionitis.
But you said there's no foul smelling discharge and no fever. So then does it have a significance?
It may predispose the child towards early onset sepsis.
if when you are suspecting anything in the baby, then all these things will add up, small things to build up your story, right? Okay. Now this baby was discharged on day 1. So what's your comment on that? Is it okay to discharge on day 1, same day of delivery? Do you all discharge on the same day of delivery? Ideally, when should you discharge? What are your thoughts on that? So in other words, we are discussing what is the criteria for discharge of a normal delivery new baby. Come on, some thoughts.
So normal vaginal delivery with a normal birth weight, adequate breastfeeding, sucking well. So same day can be discharged. Yeah.
So on day 1, will the baby be breastfeeding well?
No, the milk output on the day 1 is less. So usually we discharge by day 3 because we have to monitor the breast milk output, also how well the mother is latching, breastfeeding well or not. So in a hospital we discharge on day 3.
So what else gets taken care of by day 3?
Child will pass urine and stool.
So pass urine and meconium or stool, then?
Vaccination also, like BCG, hepatitis,
Okay,
and
BCG, hepatitis B or
Yes.
OPV. What else?
jaundice.
Jaundice, the commonest problem, jaundice. It starts by day 2, right? Any other things that can happen by day 3, we normally don't look for it, but okay, hypoglycemia. Any,
Screening we do. Basic neonatal screening that we do. So after day 3, we will do everything like neonatal screening and everything. For IEM also.
Okay. So you can send the screen. The reports, of course, will take time. Okay. Any CVS problem that can be ruled out by day 3?
After 24 hours, we do critical congenital heart diseases.
Very good. What else? Any simple clinical examination which is very useful or which can tell you that, okay, mostly no big CVS problem.
Pulse ox test, pulse oximetry test.
Yeah, which is what she said, no? Any other? What is the importance of a split second heart sound? When does the second heart sound split?
During inspiration.
Yeah, a day of life. So if a second heart sound is not split on day 2, if you are confident that it has not split, then you are looking for possibly a single second heart sound, which means you are looking for a lot of congenital CVS anomalies. And the other way around, if it is split on day 2 and you can make out very clearly that it has split, then a lot of problems are ruled out, right? Okay. So that's all. This is the importance of discharging on day 3. Now again, when I asked you, is it okay to discharge, and you said baby is feeding well, and I asked you, will the baby feed well on day 1, you should have qualified your answer with a multiparous mother versus a primigravida mother. So primigravida breastfeeding, there will be a lot of problems, latching, this, that. Multiparous mother might start producing breast milk even on day 1 very well. So if baby is sucking well, it's a different issue altogether, right? Okay.
I think we have the short answer is warmth and feeding. If these two things are assured, everything takes place. What details all that. So you need to counsel the parents what all you may expect. And there we have discussed all that. But in short, like severe malnutrition, when do you send him home? One is able to maintain temperature, is able to feed. And the third is the parents are aware, they are educated, they understand, and therefore they will follow it. Okay, if they are not, then whatever you better say them. Today, all over the Western countries, it's routine to send them out on day one because the cost increases if they stay in the hospital. But while doing that, they get all the details of when to come back again, right?
Even cesarean mothers are discharged on day 2.
Tushar has asked online, would you give prophylactic antibiotics for this leaking PV more than 24 hours? Prophylactic antibiotics to the baby. What do you think? Answer, then we'll ask Tushar if he is happy with the answer.
No, sir. If the child is feeding well and passing urine and stool and taking appropriate sleep and there are no any early signs of sepsis, then I don't think we'll give prophylactic antibiotic.
Right. So Tushar, they don't want to give prophylactic antibiotics. Okay. Now on day of life 3, child was admitted in view of neonatal jaundice, and after 24 hours of birth, mother noticed child was lethargic, not sucking well, and developed jaundice on day 3. This is the story. So what do you make out of this story? Physiological jaundice come on day 3. Everyone agrees? So everybody who has physiological jaundice, you're looking aghast. You want to? Huh?
So I think a child with physiological jaundice will not present with the feeding poorly and looking lethargic. It will be a feeding well child and a child who is active but yet having jaundice.
Absolutely. So why are all of you so lethargic? You are saying, physiological jaundice. Arey, you should have fought with me. How can this story be physiological jaundice if it is true? It starts with lethargy, poor feeding, and then jaundice. I would have expected you to give me a diagnosis of sepsis, that jaundice has come up late. If the story is true, I mean, there could be problems in history or whatever, right? So you must please note all that. This is not the story of physiological jaundice.
If it's a physiological jaundice, but it's severe, do you think the baby would be lethargic? Why not? Bilirubin is high. So you think high bilirubin and lethargy are not related? There could be a low bilirubin and lethargy. For example, if the preterm, jaundice may increase. You have many other causes of physiological jaundice within limits, breast milk jaundice, breastfeeding jaundice. It could go on increasing. Do you get lethargy? Why not? It's related to bilirubin, no? Level.
So what are suppose there is a bilirubin encephalopathy, what would be the progression?
So bilirubin to cause any brain disturbance, needs to be very high, and that to direct. Indirect would cause even further higher. The direct, because there is another cause for a brain affection, not the jaundice. You get the point clearly. So if this child has a lethargy and jaundice may be physiological, but lethargy is not physiological. So you say either jaundice is pathological or the jaundice is physiological, then lethargy is pathological. That means lethargy is hiding that jaundice, and somebody gave a phototherapy, or better go home. What about lethargy? Not feeding. So I think that is the point to pick up, that this child is going to land up in big trouble.
So what could be the causes of lethargy if it is not jaundice? Here, in this story. Hypoglycemia, then sepsis, then. So these are the two big ones. Any other metabolic disturbances? So received phototherapy, no exchange, However, he remained to be less active, would prefer to sleep most of the time. So what do you make out of that? So feeding is important. You not mentioned there about the feeding, but what is important is I want to discuss the next sentences. He never looked at face when spoken to or any toy, didn't smile back, didn't make sounds, used to get startled but never looked at the side of noise. All this is, we are talking of a 3-4 day old baby. No, when was the baby discharged?
After the discharge, I mean the progression in the next few months. So how was the child in the next few months before 2 months? So this story which I have described is after discharge till 2 months when he had this paroxysmal event. So how was his development? How he was, like how his general condition was?
Okay. So when does a baby look at the face? And when can you make out that the baby is looking at the face? At what age?
2 to 3 months.
So 2 months.
Why 2 to 3 months?
2 months.
1 point.
Okay, 2 months, 1 month.
No.
So babies do look at the face. They look at the face of the mother. But when the face is brought very close to the baby, right? The focusing is for a fraction of a second. And how much is the following? Over what angle or what range?
180.
It's not 180. It starts with a very narrow angle. So they just focus the moment the face moves away, they can't follow the face at that age, at 15 days and all that, right? Similarly, when you said get startled on noise but never looked at the side of the noise. So when can they localize sound? It's 3 to 4 months of age. Okay, localizing the side of the sound, whether it's coming from this side or this side. So what I'm trying to say is that when you are presenting this history, all this you should know so that you use the correct word. So at that time, you're going to be caught on this, that do you expect this baby to look towards sound and things like that. Okay? Okay. Now, what is your impression of this paroxysmal event? What do you make out of it? It's been described there. So is it a seizure or it's not a seizure? Or what is it? What is your thoughts?
Sir, it's not a seizure. I feel it's more of some abnormal involuntary movement.
Okay, why?
Sir, like I thought it's more of dystonia because there is posturing, there is generalized stiffening, and there has always been some sort of trigger. Like I have not mentioned, mother gave history like on touching or on applying massage, and then they never occurred in sleep as well. So some sort of trigger has always been there.
So you said it is preceded by excessive inconsolable cry. So what does that suggest?
So this could be the trigger which has caused.
Cry is the trigger.
Stimulus causing the cry.
So why should normal touching cause inconsolable cry? So means I just wanted to make 2 points. One is that on a different note, whenever you get a small infant with an excessive inconsolable cry, think of it as a seizure in isolation. Here I agree that this doesn't look like a seizure because a newborn is not expected to have such generalized movements as part of a seizure. And this is obviously arching and dystonia and all that, right?
Yes, sir.
I think in the first slide we picked up that lethargy and not feeding is pathological. You can't send him back home with phototherapy. Then he said he was a little better. What was better? Okay, he was not crying maybe. Lethargy itself is abnormal. Not feeding is even worse. then at that time only you could have said, no, we'll have to admit, we'll have to keep him, jaundice is not a problem, there's something else is happening. Then my next question to you is, which neonate remains lethargic for a long time? We at our age can be lethargic, genuinely. You at your age cannot be lethargic. Okay. So, do you think neonate can be lethargic for a long time? Why not? He has no business to be lethargic. What I mean is, if lethargy is the early symptom of brain affection, the disease progresses very fast at that age, and therefore, one who continues to be lethargic is likely to be even having a post-convulsive phenomena, and the convulsions at that age is not tonic, clonic, etc., easily missed. Otherwise, nobody is lethargic unless you have given a sedative. Okay. Otherwise, a lethargy due to brain affection is not going to last long. This child is continuously lethargic. To me, that lethargic continuous is not hypoglycemia continuous, hypoperfusion, hypoxia, no. He would have thrown up a seizure. So possibly, he is throwing up a seizure. And like a non-convulsive epilepsy, where an epileptic comes with being only drowsy all the time, you start wondering whether he has an active brain disease, but he has no story, then that is non-convulsive focus of thing. I start wondering whether that long-term lethargy is that. But he said, in between he was sucking. So that means in between the lethargy was not as deep as not able to suck, which makes me strongly feel that this is an intermittent issue, and that I might put it as a post-convulsive phenomenon. Okay. In a newborn, what type of convulsions you see? I said not tonic, clonic, etc.
Subtle seizure.
Excessive crying or blank staring look or cyclical movement of the limbs.
Or
Subtle seizure.
subtle. So what are those other subtle seizures?
We can stare.
Staring look. Okay.
Okay, which is easily missed. Okay. After all, what you have is paroxysmal similar episodes. If I suddenly stare at you, then don't. It's enough to say it's a seizure. So they are easily missed.
Tushar has asked from online, what is the difference between angelic smile and social smile?
Spontaneous smile is spontaneous smile is angelic smile, and at 2 months what develops is social.
So what is a social smile? When will you call it a social smile?
Baby smiles in response to someone's voice.
So in response to environmental stimulus, right? Fine. So now all these movements kept occurring, and intermittent protrusion of the tongue thrusting you have said. Then new onset paroxysmal event, sudden forward drooping of head. So now this is what age roughly?
Sir, now he's 7 months old, so 25 days back, or nearly 6.5 months, he had this new episode of convulsion.
Okay. So now, is he holding head now? So this forward drooping of head means exactly what? So even in a supine position, he lifts up.
I've got the video, I'll show.
Okay, we'll see that. We'll see that. Okay. So now, what do you make out of the whole thing now?
This is simply epilepsy. Family history of epilepsy. He's getting a recurrent seizure. Why waste time? No? How can you ignore family history of epilepsy?
So what is your, you agree with sir, or you want to connect everything and kind of start summarizing?
Epilepsy is unprovoked recurrent seizures. There is no provoking here. Okay. It's recurrent. Definition of epilepsy and family history. Give him valproate or carbamazepine, whatever you want, and send him home.
Okay, so first, is it epilepsy? Answer, sir.
So I don't think so. It's epilepsy. It's a developmental delay. It's not frequently we don't see in epileptic children, and at 2 months.
What is a better way to answer that question?
So these seizures doesn't look like unprovoked seizure. There is something underlying, like the child developed lethargy, and the way he developed arching, there is dystonia, then the semiology is changing. So, so there is some underlying pathology which has to be.
So, means as a pure thing, recurrent seizures is epilepsy. But this epilepsy is symptomatic of something. It is not just an epilepsy. So your answer, don't say this is not epilepsy. You say this epilepsy is not the only thing. Epilepsy is a symptom of something underlying, as you said. So now what is the whole story? How would you start putting adjectives and add? We can do a collective summary also. So, full term or preterm?
Full term.
Normal delivery?
Normal delivery.
Born to a elderly multigravida. Okay. Antenatal history?
Significant.
Antenatal.
Anemia.
Anemia. So anemia can cause all this. Mother's anemic, so baby's anemic, so hypoperfuse, so brain injury.
No.
Huh? What a fantastic story. So what is the significance in the antenatal history, if any?
The leaking PV.
Can that cause this?
Sepsis.
Early onset sepsis can.
So you think early onset sepsis would be given phototherapy and sent home in 10 days? Or the giving phototherapy was wrong but sepsis was right? What do you think? Do you give phototherapy in sepsis? Yes or no? So I think all of you are wondering, what a difficult question. What is the bottom line of phototherapy and what is the bottom line of jaundice in sepsis?
Direct hyperbilirubinemia.
So jaundice in sepsis is direct and phototherapy is never for direct. It is always for indirect. So the two things are 180 degrees apart, right? So either phototherapy was wrong or sepsis is wrong. So what else?
A significant postnatal history of jaundice.
Okay.
Lethargy.
Yeah, but are we able to connect the jaundice? So do you think this is hyperbilirubinemia which has caused all this in this baby?
The lethargy started first.
Lethargy started first and jaundice was noticed on day 3 of life. So which is not your classic pathological jaundice which will go to no end and cause all this, right?
Remained unnoticed. And they noticed lethargy first.
For a few hours that is possible, but then as sir said, if they noticed lethargy first, it was not due to the jaundice. Jaundice was separate. And a jaundice which is rapid, we are trying to answer, could jaundice have caused the whole problem? That has to be very severe jaundice which can't be missed. And very fastly progressive jaundice, right?
So the child was discharged on day of life 1 and he came back with decreased in feeding. So there could be neonatal hypoglycemic brain injury.
Yeah, it could be hypoglycemia. So antenatally, I don't know how much we can attribute causative factors. We don't have big solid things. But postnatally, yes, there could have been hypoglycemia. Sepsis, we don't know. We can postulate sepsis. But what more? Beyond that, what other adjectives or inferences you have reached? So where is the anatomy of the problem?
Basal ganglia.
And
The cortex.
so it seems to be multifocal, right? So that is one. So gray matter is involved in more than one area possibly. static or progressive?
Stat.
So fight. Why static and why progressive?
Static, sir, the child has not lost any acquired milestones.
What has he acquired to lose? So what is our concept of static or progressive in these first few months? Is failure to achieve static? It's progressive, no? The DQ is worsening with each progressive month, right? You have new onset seizures coming up, new semiology seizures coming up. So it's definitely progressive, right?
So I think the anatomy is a diffuse encephalopathy. That's the way we put it. What's the possible pathology? It's not inflammatory, it's not degenerative, so it has to be metabolic. Okay. And by metabolic I mean neurometabolic. Okay. But unlikely just syndromic, because that would not have been progressive like this. So between inflammation, degeneration and metabolic, this is neurometabolic. Which metabolic? We have no idea as of now. But jaundice is not due to same metabolic disorder, because we have separated that out. So this is an isolated neurometabolic disorder with no other organ involved as yet. Okay. In which a seizure has come up early to my mind. Though the visible seizures, manifest seizures have come up a little later. But even earlier. Okay. And to that extent, this must be a severe neurometabolic disorder. Okay. And that's why it's progressive. Now the question is, which kind of neurometabolic disorder? Can we go further? Could it be primarily a white matter and then grey matter? Or could it be first grey matter and then white matter? We haven't seen any evidence of white matter as of now. Okay. So what do you think? What must be the first beginning story? Because both ultimately in a phase, and that's another evidence of progression. That it starts with grey matter, ends up also with white matter, or vice versa, which is obviously a progressive. So what is the prominent feature? Drowsiness and probable seizures. So where is the problem? Grey matter. Okay, and now we will see whether it's stiffness, etc. That also adds to the, and then some startling, which makes us know that it's a progressive neurometabolic disorder. We have no idea as of now which metabolism we are talking about.
There's a comment on the chat, remote symptomatic epilepsy. So let's understand that word. When would you call it remote symptomatic epilepsy?
If there would have been hypoglycemia, and later on due to gliosis it is causing seizures, so that would be a remote symptomatic, like the insult has happened in the past and right now it's causing seizures.
So there's a big gap between the insult and the onset. So maybe months, maybe a year, maybe more than a year, something like that, right? So that term is not very appropriate here.
You use remote, no? At a distance. But sometime very near, sometime very far, same remote. Okay. But why not immediate? Damage is at birth. Seizure is later. What remote? But how remote? Remote could be few years also. So what is this concept of remote? There has to be some concept, no? Why does remote come any time? Not only few hours, few days, few weeks, few months, few years. What kind of remote is that? So this is called an epileptogenesis. And unless there is an epileptogenesis occurring, damage has occurred. But the damage must lead to epileptogenesis. And then only a seizure, and typical hypoxic ischemic, very severe at birth, will have a seizure maybe right at that time, which is acute symptomatic, Then for 3-6 months there is no seizure, and then he starts seizuring. First seizure was acute symptomatic. The 3-4 months later, it is epileptogenesis, which means it's going to continue now.
So, in such a baby, it's a little difficult to pinpoint what is the developmental level. So, maybe, it's better to say less than 15% instead of 15%, because you are trying to look at the first big identifiable milestone, which is social smile or looking at the face or whatever, right? Okay. So, global developmental delay. Now, feeding. So, exclusively breastfed for 7-8 days and then top feeds 2 scoops of formula in 30 ml water.
So the dilution of the formula powder. So she was feeding the child with lactogen. So she used 2 scoops in 30 ml of water.
So it's less dilution, or it's over diluted or over concentrated?
More concentrated, sir.
So what will
1
that?
scoop in 30 ml of water.
So what is the implication of that? First of all, I think nobody will do this. But suppose it was actually done. Why nobody will do this is because they would do it the other way around. They would dilute it because of the cost factor. So using 2 scoops would be like a gross error only. But now tell me, what would be the implication if it's really done?
So this can cause like electrolyte imbalance, like hypernatremia.
Very good. So one is hypernatremia. Second?
Hypernatremic dehydration.
Okay. Then hyperosmolarity. Okay. So all the consequences of then hyperosmolarity. So hyperosmolarity would lead to renal solute overload. It would lead to other electrolyte disturbances, right? Because 2 scoops in 30 ml is like real concentrated, right? Okay. And now child is fed with diluted cow's milk, right? So this formula was used for how long?
So like since 4 months of age, she has started feeding the child with cow's milk. So she told she can't afford the formula. So that's why she has started feeding the child with cow's milk since 4 months of age.
Okay. So for the first 4 months, baby should have put double the weight, no? 2 scoops in 30 ml. What do you think?
Feeding was like insufficient or inadequate.
How inadequate? It was 2 scoops in 30 ml.
So the intake.
Quantity.
The quantity the child has taken or sucked.
So what I'm trying to say is be very clear on all this, because this is all, it should come very smoothly that yes, this baby is underfed. That 2 scoops strikes at you. Okay. And especially in such a baby, you have to specify, so like you said, quantity. So if the baby, so you should say that baby is taking very little quantity or baby is taking a long time to swallow. So you should specify, because that is very important in such a baby, that there are feeding difficulties, right?
Again, here a problem. Do you think 300 ml of diluted cow's milk gives 12 grams of proteins? Which cow is this? So how much is the protein in cow's milk? 100 ml of milk, undiluted. How much is the protein?
3.3 grams.
And to get 12, you need 400 ml of undiluted, and here 300 ml of diluted. We have diluted our thinking. Okay, so take a note of that. Last time we said, you just put some figure, examiner, unless he is partially drowsy, lethargic, he will pick up and he will forget the diagnosis, he will ask you, and then he will say, no, this is the most important for our country. Neurodegenerative is not important. So again problem. So take a note of that. They can't be 12 grams. Yeah.
So now come and summarize and then we take it further.
I'll reframe it. 7-month-old boy, fought by birth order, born of non-consanguineous marriage, with significant birth history of lethargy, NICU stay in view of neonatal hyperbilirubinemia with global developmental delay, partially immunized, now presented with abnormal involuntary movements, most likely dystonia, with spasticity. Since the age of 2 months, with a new onset seizure, seems to be a case of progressive encephalopathy. So then first in the list I'll put a neurometabolic disorder, then second cerebral, second inborn errors of metabolism, and third cerebral palsy.
So actually, if you decide that this is progressive, which all of us strongly feel it is, you shouldn't put cerebral palsy as a differential at all.
But we may not be so sure about progression at this age. Then what are the points against it being a CP? Progression, yes. But progression is our belief, our kind of trying to convince you that no, it's not static, it's progressive. Are there any other factors to say that this is unlikely to be a cerebral palsy?
One very big important thing.
When do you diagnose cerebral palsy as an etiology?
During this time we call it hypoxic ischemic injury, as in when the developmental milestones after usually age of 4 or 5 we term it as cerebral palsy. Not very sure.
So you are saying that 7 months is a little early to label as cerebral palsy. So that's a different issue. What else?
There should be some perinatal, intranatal, or immediate postnatal insult to the hypoxic insult to the developing brain, and that is when. So that is not there in this case.
So it need not be hypoxic all the time, and it is there on that day 2 or 3 when the baby became lethargic. We don't know what. So that's perinatal kind of.
CP doesn't start normal at birth. This child was normal at birth, sent home. CP cannot start normal at birth with an exception. First statement is universal, right? Exception.
Dystonia.
And the exception is a milder damage, which may present a little later. But he is presented so early. So damage has to be severe. If damage has to be severe, seen right at birth, one who is normal at birth for 1 day, 2 days, 3 days, whatever, is unlikely to be CP as a rule. And this child has been normal, sent home, came back, but normal. Okay. That means clinically normal. They might have missed something word, but clinically normal. That's why it's not CP. Anything which is normal for a day or 2 or 3 and then develops is unlikely a CP unless it's very minimally damaged. And minimal damage can be seen as a learning difficulty, okay, even in school age, but not this, right?
And the second thing is
why
that...
are you calling hyperbilirubinemia? He's being sent home, no?
Yeah, that's what I was...
So if the damage is due to hyperbilirubinemia occurring due to pathological jaundice, then also will the child be normal at birth if it is dyskinetic CP?
The question is right. Therefore, hyperbilirubinemia is not CP per se. CP diagnosis, yes, static motor disorder, okay. Therefore, this typically is not just the motor pyramidal, but extrapyramidal. He put it possibly because there was some irritability, crying, arching. But where is hyperbilirubinemia? He was sent home.
We discussed, na, the sequence is
No
not
kernicterus.
of yeah,
Okay.
kernicterus. So you shouldn't use the word kernicterus in your summary, because if you are going to, if whatever history you have given us, the sequence is all haywire. So you can't say this is first kernicterus and then everything happened. It didn't happen that way.
And again, hyperbilirubinemia is kind of acquired. Okay, it has not been since birth, or not perinatal. So it's an acquired. Now, in definition, cerebral palsy occurs when the brain is damaged during growing periods. So you are right there. It was growing period. But it is not strictly, yes, it is called a type of a cerebral palsy, because ultimately it fits in a definition of cerebral palsy. But it's not strictly a CP, it's a hyperbilirubemic kernicteric damage. This is not. So that kernicter is even doubtful, no. It's possibly not kernicterus, yeah?
Go ahead.
So this is the picture of the child. We put on video of the.
What is the head circumference?
Large, apparently large.
What do you think? Looks small, looks large, looks average?
Large.
Looks average. Anybody for looks small? Okay, good. At least nobody thinks it's small. Large compared to whole body. We'll have to actually measure and see whether it's actually large. What else did you notice in the video?
So flexor spasm.
Drop attack. So you should identify that as a myoclonic seizure. That was a myoclonus. Okay, that sudden this thing. And that is why, if you remember, I asked him, is he holding his head? So if he is not holding his head and still his head is coming forward like that, it is a flexor spasm. And that's why it's a myoclonus, right?
He seems to have low set ears, as we see in this fourth picture.
So vital signs on examination, child was afebrile, heart rate was 126 per minute regular, RR was 34 per minute, abdominothoracic type, peripheral pulses were well felt, regular, normal in volume, corrector, no radioradial or radiofemoral delay, CRT was less than 3 seconds. So anthropometry, weight is 4.6 kg, which comes to be less than -3 standard deviation. Height is 54 centimeter, which comes to be less than -3 standard deviation. Head circumference is 43 centimeter, which comes to between mean to -1 standard deviation. And weight for length is 0 to +1 standard deviation. So the child is severely acute malnourished.
Head circumference is 43 at 7 months. But anything else you want to do? So what is that? You're telling us why you didn't take engineering. He's calculating on a calculator. What is the formula?
Length by 2 plus 9.5.
So length divided by 2 is how much?
So 27 plus 9, 36 plus minus 2.5, it's macrocephaly. Isn't it? Yeah, it should have been 38.5 plus minus. He's going beyond that.
So confirmed, Megalencephaly or hydrocephalus?
Minus.
Height is also less than the centiles.
So you're right. So take it forward. Answer, complete your answer.
Head sparing.
So you can compare the two when both are growing okay, no? If here the height is not growing okay because of a disease, then you can't compare the head with the height, no? So then this formula won't hold true, right?
Then how do you know 43 is small, no? 43 is small, isn't it? How much should be a 7 months old head to be?
Birth is
34.
33 to 35. Then 2 centimeter per month for 3 months. Then
1 centimeter per month.
so first 3 months 6 and the next 3 months 3. So 9 centimeters. So 33 plus 9 is 42 and 35 plus 9 is 40. So we don't know what was the birth circumference.
I remember in one of my co-examiner, when you start calculating, he would say, you must have done 1,000 patients' head circumference or height. Do you need to calculate even now? Okay. So I think quickly you should get about talking about it, isn't it? Yes.
So head to toe examination. Child is in the supine position. Frontal bossing present. Skull shape was positional plagiocephaly. Wide open anterior fontanelle. Features of rickets were there. Thin build. Pallor was present. One neurocutaneous marker in the left chest, capulite spot. Arching of the back is seen, and low set ears, and no other dysmorphic features. Normal chest, abdomen, spine, and genitals.
I know this neurometabolic disorder has also affected the kidney. I can see that. I said we have to watch and see which other organs are affected. I think kidneys are affected. Don't you think so? Which part of that statement tells me kidney is affected?
Rickets.
Rickets. Okay.
Yes, sir.
Sure. What's your comment on rickets? Could it be deficiency rickets only?
Yes.
Yes?
It seems like deficiency.
How do you convince me it's a deficiency rickets? I'm sure this disease has not involved the kidney, but to me it has involved. So convince me it is deficiency only. Pallor is deficiency, no? Vitamin D is deficient. You agree to that? Who will shout at me and say, what nonsense? So are you respecting me and not shouting? What's wrong? Tell me why not? It cannot be deficiency. Either he has no rickets, he is wrong, or deficiency is out. Deficiency rickets is seen in a well-growing child, never in a malnourished child. So this cannot be deficiency. So this may not be rickets. We will have to check on that. But if it is so, then it's a kidney disease. Yeah. But there are no other signs of kidney, no symptoms. Can it be still renal disease? Why? I thought kidney means oliguria, hematuria, edema, nothing.
Is there any other sign which could be kidney?
Kidney means that, no? Oliguria, edema, hypertension, hematuria, nothing of that kind. Only rickets.
Anemia.
Pallor and failure to thrive.
Failure to thrive. Growth failure, no? That can also be kidney. We don't know, but we have to check. Okay.
So, systemic examination. Child has been examined in the mother's lap and he was irritable. No fixing and following to light. Gag reflex was present. Abnormal intermittent dystonic posturing has been seen. In the motor system examination, inspection, extended posture with arching of the back, muscles felt taut. On passive stretching, tone increased in all the four limbs, spasticity, power, spontaneously moving all four limbs, plantars were bilateral dorsiflexion, and reflexes, only knee was brisk, the others were 2+. Sir, in 180-degree flip examination, the child could, on ventral suspension, child could elevate the head in the plane of the body momentarily. In the prone position, head was turned to one side, he doesn't lift chin. And no, on pull to sit, no head control and back is partially rounded. On axillary suspension, scissoring is present. And in the supine position, he has got extended legs. Neonatal reflexes, sucking reflex is present, rooting is present. Palmar and plantar grasp is present and Moro's present. So some Moro's we got incomplete. We could only find the abduction part of Moro. We could not find out the entire adduction and flexion.
So what does that mean?
So this could, that is incomplete Moro.
Yeah, so incomplete Moro, but in a 7-month-old baby. So what does that mean?
Cerebral palsy.
Persistent of primitive.
So first is persistence of the reflex beyond its normal period, which is abnormal.
Abnormal.
Right?
Yes, sir.
Now, what does the incomplete mean? So it may be in the process of getting lost over another 2-3 months. So you will not get a classical one. But what is the other incomplete things that you should be looking out for? Suppose there is Moro's only on one side.
Fracture clavicle.
So fracture, baby would be crying. But a congenital hemiplegia or something like that. So keep in mind all that when you have such incompleteness, right?
Sir, in this case, the reflex has persisted beyond 6 months. So, sir, should I consider it as persistent Moro or like on the verge of disappearing?
But Moro's, when is it supposed to disappear?
4 months.
So it is well beyond that age, no? So it is abnormal.
So other systems were normal, no associated abnormality. So I'll just... No.
Okay. So now, what is everybody's impression? What did you get after the findings? So we have to take a finding and look at its interpretation. So pick up any finding and tell us what is the interpretation. So dystonic posturing suggests what?
Basal ganglia.
Basal ganglia involvement. Then
it's written that there is spasticity, but I was assuming that it would be rigidity. So was there any rigidity?
So we felt more of spasticity, sir, but no patient type of thing.
what's the difference between spasticity and rigidity?
So when the tone is increased throughout the range of motion and not velocity dependent, it is rigidity. And spasticity is clasp knife spasticity, which is velocity dependent. So there is catch in the end.
Very good. And suggestive of what?
So spasticity is suggestive of upper motor neuron.
Pyramidal
tract, white tract affected, white matter affected, while rigidity would be basal extrapyramidal.
So it's pyramidal tract anywhere is spasticity and rigidity is basal ganglia. So yeah, so they thought it was spasticity. So which means what? Multiple areas. So you got basal ganglia affection, you've got pyramidal tract affection. What else have you got on examination? Any other positive findings?
Visual involvement probably.
So visual, not fixing and following. So that could be what?
Blindness.
It could be.
So, I mean, second eye examination, pupils, reflexes.
Pupils were equal in reacting to light, but there is no fixing and following to light.
So whether it is second nerve damage or there is cortical blindness, that I would be more sure if pupillary reflexes are there. So
yeah. So if both, so pupillary reflexes, he's saying reacting to light means what? Which reflex is present? Direct is present. So that's what is intact? Optic. Second nerve is intact. And what is the test of the third nerve?
Confrontation.
So movement, right? So that you can't test here. And if consensual is also present, or if there's a difference between direct and consensual, then what does it tell you?
RAPT.
So if in the, say, left eye, direct light, pupil does not constrict, but light shown in the right eye and the left eye, pupil constricts. Left optic nerve, right? Yeah. So, fine. Okay. So besides this, of course, on examination you have confirmed the developmental delay, right? You've confirmed that there's developmental delay. You've said abnormal persistence of neonatal reflexes. So, as we said on history, as Sir said, that it's a diffuse involvement of the CNS, right? And about progressive and static, I mean, from the history, it does look like progressive. So I don't know, I'm not confident calling it CP. And then Dr. Narendra Rathi has made a point that we started discussing it as a grey matter disease. And CP is a predominantly white matter disease. So again, the discrepancy.
I think if you look at an overall neurometabolic disorders, the ones who present very early, in the first 2-3 months, are likely to be grey matter than white matter. And those who present around 3, 4, 5 months of age are more likely white matter. But certainly there is an overlap. When the whole thing is fastly progressive, history doesn't pick up white matter easily unless it is severe, but the grey matter is picked up very early because lethargy, seizure, etc. So we are not very sure about whether this is primarily a grey matter or a health matter. Fundus examination might give us an idea. On one hand, you may have an optic atrophy. On the other hand, you may have a visual problem. So some differences possible. But we are open at this time. But whenever you are looking at a neurometabolic disorder early in infancy, you must mention few more things which are often associated. One is, of course, startling. This child gave us that history. Yes. Second is, of course, the fundus. Okay, whether there is any obvious evidence of white or grey matter. But what else are accompanying features? Any skin rash, any peripheral neuropathy, so, and smell of the urine, color of the hair, color of the skin. Okay, so phenylalanine, so PKU, okay, MSUD, okay. These are the two common grey matter neurometabolic disorders in the first 2-3 months. Okay, so MSUD and PKU. So you have any color change? Okay, so you might pick up such things. Some neurometabolic disorders have peripheral neuropathy, so you need to say no evidence of it, skin rashes. Then of course an investigation, some have thrombocytopenia, etc. So I think try to make your clinical impression as wide as possible. Finally it's only the test, and the test also may not sometimes exactly give you where it is, then molecular tests, etc. But I think that is what here we should be open to see whether both have things. But it appears that seizure have come up early, lethargy has come up early. So maybe it has been a grey matter ending with white matter, but both can come very together. But typical Tay-Sachs, Sandoff, etc. start around 3, 4, 6 months of age. Okay, but of course they could start early too. Okay.
So in the exam to put up a diagnosis of CP, I would argue that a dystonic CP is typically seen either after severe birth asphyxia, which here there is no such story. For Kernicterus, and then they don't have such profound global developmental delay. It's a disparity between the motor and the other. Same is true of Kernicterus and chorioathetoid CP. Their higher functions are not so badly affected. So I would argue again for as these points to say that it doesn't look like CP.
So we have done one MRI it was done from outside actually.
These changes are not specific for a single etiology, clinical correlation.
We said that. Even taste may not. Then why are we afraid not to opine? Isn't it? Yeah. After all, he says clinical, so we are doing that.
Anything in the other investigations? Nothing special.
No. The SGOT and the SGPT are slightly deranged and the ALP is also elevated.
Is 0.6 creatinine normal?
RFTs are deranged.
Normal 0.6. I know up to 1.2 is normal, but that is not right. Yeah.
The EGFR.
54 centimeters, no length.
Three-fourths, no? Yeah.
Saying EGFR around 50. 40. EGFR around 40. So first of all, that formula, the constants are different for this age. Okay. It's not the same as your 0.55 which you take for that's for a 2-year-old or older, right? But nevertheless 0.6 is high for this age. So it needs a relook into that. Yeah?
Take a note of it, not very important, but certainly it looks higher than expected.
Fine, so let us know next time. So incidentally, last time we were discussing that PFIC type, no? So what happened? Liver biopsy, anything?
They haven't followed up yet with the report. We're still awaiting the final report.
Okay, so we move on to the second case for today, which is being presented by Dr. Priyanka, sorry.
Can I give you one homework? One day you will have a child, or your family will have a baby, and they should not have this problem. So, you have 7 days. Write down a solution how me or my family or friends will not have a baby like this. Any takers? Take my phone number. Message me your solution. We meet next Thursday. 98-232-81 447. 9823281447. Thank you.
Good evening. I'll be presenting the short case for today. 1 month, 8-day-old female child, first by birth order, born out of non-consanguineous marriage, resident of Mulund, hailing from Latur, Hindu by religion, Biradar by community, was brought by mother with complaints of yellowish discoloration and passage of high-colored urine since 10 days prior to the admission. Child also has a significant natal and postnatal history, which will be discussed in the respective section. The child was apparently alright 10 days prior to admission when the mother noticed yellowish discoloration of eyes, which was progressive in nature and it progressed gradually to involve the face, limbs, and eventually the entire body. The mother also noticed that the child was passing high colored urine and there was staining of diapers with dark yellowish colored urine. The mother consulted a local doctor for these complaints and then she was advised to breastfeed adequately. But even after that, the symptoms didn't resolve, so the mother went to the doctor again and consulted. When certain blood tests were done and she was told that the child has developed jaundice, for which she was referred to a hospital. There is no history of passage of clay-colored stools, no history suggestive of any bleeding manifestations, no history of irritability, lethargy, refusal to feed, no history of fever, rash, no history of passage of bulky or sticky foul-smelling stools, no history of phototherapy or exchange transfusions, no history of vomiting or history suggestive of any feed intolerance, no history of blood transfusion or any drug intake, no history of suggestive of any liver disorder in the family, no history of convulsions. Antenatal history, the mother's age was 28 years at conception and father's was 31 years. This was a spontaneous conception. She was registered at the 4th month of pregnancy. All the supplements were taken adequately and injection TT was taken. The mother underwent 3 ANC scans. The first scan was done in the 4th month and she was told that the scan was was normal. The second scan was done in the 5th month and she was told that query breech presentation of the child was present. The third scan was done in the 8th month, which was also told to be normal. There is no history of any intake of medications, radiation exposure, no history of any antenatal complications in the mother, no history of repeated fetal losses or early sibling deaths in the mother. This was a full-term child delivered by vacuum-assisted delivery. Baby cried immediately after birth. The birth weight was 2.7 kgs. The child was admitted in TCU where he received O2 by nasal prongs for 2 days in view of development of respiratory distress. On day of life 3, the parents were counseled about Down syndrome and they were also told about presence of an opening in the heart, query a small OSASD after doing an 2D echo. The child was then shifted to PU for observation and from there karyotyping was sent on day of life 6. And the child was discharged on day of life 12. The child has received the birth vaccines. The child was started on cow's milk initially in view of low breast milk output to the mother. Then later was shifted to express breast milk and the child was given feeds by Vati spoon feeds. Then this was followed by direct breastfeeding. At home the child was exclusively breastfed 3 to 4 hourly, feeding on demand. The child was passing stools and urine adequately in quantity except for the passage of high colored urine. The developmental history, startled response is present, the child recognizes mother, social smile is present, the child cooing is present. Neonatal reflexes, sucking, rooting, palmar, plantar grasps are present. No history, so this is the first child, there is no history of any previous conceptions or miscarriages. No history of any congenital inherited disorders in the family. The family belongs to the lower middle class according to the modified Kuppaswamy scale.
Wait, just go back. Okay, so So 1 month, 8-day-old baby presenting with jaundice noticed 10 days back, right? Was there any neonatal jaundice? Nothing in the newborn period. Okay. So what are your thoughts on that? Come on, we had another similar case last week only.
So it is conjugated hyperbilirubinemia because there has been staining of the diapers.
Very good. So conjugated hyperbilirubinemia starting at about 20-25 days of life. So next statement should be what? Come on.
In a child who is feeding well.
In a child who's
growing,
so we don't know whether the child is growing well at that age, at 1 month or 20 days. So that time we don't know, that is one. And the second is, you notice that there was some problems in feeding, initially low output, then express breast milk and all that. And there was a advice given to improve breastfeeding. So what's your comment on that? She said, na, with the jaundice, when she went to the doctor, she was told that with feeding it will improve. So what's your comment on that? Advice to breastfeed adequately. Come on. If the baby was breastfeeding inadequately, what is that jaundice called? When do you see that jaundice? After no jaundice, you see it at 20 days or 25th day for the first time? Never. Right? And that jaundice is unconjugated. This is conjugated jaundice. So this conjugated jaundice has nothing to do with less breastfeeding at 25 days of life. Right? The two things are different, even if the breastfeeding is inadequate. Okay? So what could this be? So again, primary liver disease, primary hepatocyte disease, primary biliary tract disease. How will you separate out? What do you want to ask? What do you want to see?
Any other sign of liver affection? Other signs of liver affection?
So what signs do you get at this age of liver affection? Do you get edema feet at this age?
Some bleeding tendency.
So some bleeding tendency. So you ask for any ecchymotic spots or anything. What else?
Is it a sick looking child or a non-sick child?
So whether the child is sick or not sick. Okay. Then?
SGA baby, IUGR baby, whether I would suspect torch infections or I would suspect a biliary atresia. That way.
So birth weight normal versus a IUGR baby. Then?
Any other systemic involvement?
Okay. Feeding now,
Sepsis.
feeding well, wanting to feed well. So again, inadequacy of breast milk and subsequent inadequate feeds is less food being offered to the baby, but is the baby wanting to feed? The active, all that you want to know to decide whether that's hepatocyte problem or no, right? Yeah. So what is your assessment of all this? Come. What we discussed just now, what is your assessment? Is the baby active, wanting to feed?
So the mother said. So mother said that she was feeding on demand. So like that was around 3 to 4 hourly. The child would want to, like the child would cry and then the mother would feed.
So if a baby is getting inadequate feed, this baby feeds at longer intervals or at shorter intervals? shorter interval. So this baby wants to cry and feed more and more. So if the baby is not wanting to feed for 3-4 hours in spite of inadequate feed, I would take it as a not feeding well baby, means I would take it as a sign of hepatocyte. Then
So there was like no clay-colored stools. So the mother is not giving any history of clay-colored stools. So only high-colored urine is there. So less likely to be any surgical causes of jaundice, because in that you would expect more of clay-colored stools.
So anyone wants to give a caveat to her statement? No history of clay colored stool rules out surgical causes.
So actually we have to cut the stools to see if there is any clay colored.
Partial obstruction can.
Or
Sloughing of the
The sludging of the epithelium causes the coating, which might give a false yellow stain.
the epithelium of the intestine is loaded with the bilirubin and that can coat the stool, right? Okay, fine. So this is a small caveat that sometimes you may get fooled by a absence of clay colored stool. Stool is clay from inside, but outside it looks yellow. Okay, fine. So tell us your summary.
So 1 month, 8-day-old female child presenting with gradually progressive jaundice with high-colored urine without history with suspected Down syndrome is a case of neonatal cholestasis to rule out. So extrahepatic biliary atresia, choledochal cyst, or metabolic liver diseases.
So what's the connection of Down syndrome to neonatal cholestasis?
So in Downs, if there is, hypothyroidism, then there will be persistence of the jaundice, neonatal jaundice. But this is presenting as direct hyperbilirubinemia. So Downs, constipation.
No history of constipation.
So no history of constipation, you are saying from what angle? From hypothyroid angle?
Yeah.
Okay. So, if there is constipation, what would you call as constipation in this newborn baby? Not passing stools for 4 days is constipation?
No. The consistency would be.
So the consistency and frequency both should be less. Then you call it constipation. Just not passing stool could be normal, right? Yeah. But that is not like a make or break to diagnose a hypothyroid.
Yeah.
Okay? Okay. So now what you have said is right in your summary, but I am asking you that you said that there is no acholic stools, but still you said first thing to rule out is extrahepatic biliary atresia. Why?
So for metabolic liver diseases, we would expect more of the child would be more sick. Like this child was comparative. Like the child is active, playful, is not that sick. Also, there are no bleeding manifestations. So in metabolic liver disorder, the child would be more sick looking as.
Okay. Anything else? So what you would say in the exam is that when I don't have absolute clear-cut differentiation on history, that is definitely a liver disease, then it is very important to rule out a surgically treatable cause, and that's why I would rule that out with the help of investigations. When it's absolute clear-cut one way or the other, it's different thing, right?
On examination, the child was lying on the bed. The child was awake, active, and playful. Hypotonia was present. Child was euthermic. Heart rate was 130 per minute regular. The respiratory rate was 40 per minute regular. Abdominal thoracic type of breathing, no distress. Saturation was 98% on room air. Peripheral pulses were well felt, present at all the peripheral sites.
Slow. We had enough of Shami yesterday.
Peripheral pulses were well felt, present at all the peripheral sites, adequate in volume, force and tension was normal, with no radial or radiofemoral delay. The CRT was less than 3 seconds. Anthropometrically, the weight of the child was below -3 standard deviations, length was between -3 and -2 standard deviations, head circumference was between -3 and -2, the weight for length was below -3. The child saw failure to thrive. On head-to-toe examination, anterior fontanelle is open at level. The child has a flat face, flat occiput, mongoloid slant is present, low set ears.
One sec. You have the baby here?
Yeah.
So let's put on these lights and again 2 volunteers to come and examine the baby. आप इधर बैठो. Come. You can come there.
Child is lying comfortably in the mother's lap.
Hold close, huh?
Color of the skin is deeply yellow. The muscle mass and build is poor. There is a facial asymmetry, like facial syndromic features in form of mongoloid slant, this flat nasal bridge.
So she mentioned a flat face. How do you make out a flat face?
Nose is flat nasal bridge and less prominent maxilla. And
Yeah, but how do you identify it? So you have to say that I have to look at the face in profile. So you don't have to look at the face straight. You have to look at the tangential face, and then you will see that all those curves are not there. It's a flat face. Okay? Then
Occiput is also.
yes, sir.
why do they have a flat face, flat occiput? Do they have oligohydramnios, polyhydramnios, mothers, or nothing?
Oligohydramnios. Oligohydramnios.
I think it's related to that, but check on that.
Flat occiput in a hydrocephalus? In a hydrocephalus, you must talk about the occiput.
Positional.
So could there be a flat occiput in a hydrocephalus? Which tells you what kind of hydrocephalus that is.
If posterior fossa is empty, in that case, flat occiput.
I didn't get you. Posterior fossa. So in Arnold chair, you get a flat occiput. In fact, they are more dilated, no? Posterior.
Because of the less movement of head, static position of head.
So postural is one
Postural.
issue. So yeah, so that's about it on inspection. Fine. Now you can examine the baby. उधर लेटाना जरा. You come here. Come from there.
AF is 8 level. Posterior frontal is not. Sorry. Posterior frontal I cannot appreciate. Okay.
Posterior fontanelle is open. So abnormal or normal?
Abnormal, sir. Posterior fontanelle closes 2 to 3 months after birth.
So this baby is.
Oh, 1 month.
So this is normal. Okay.
Low ear is not prominent. Like
Okay.
there is no low set ear. Chin is little micrognathia is there. And there is no other rashes or any skin malformations. This is no clinodactyly or Ximian crease is not found. No sandal gap.
You think this gap between the first and the second toe is more? Not convincing. Okay.
Umbilicus is normal. Shape of the chest and abdomen is normal. No any flank fullness or protuberance of abdomen on the upper side. Palpation I can. There is a plus 2 centimeter hepatomegaly, which is form in consistency.
So before calling it hepatomegaly, what should you do?
Liver span.
Span.
Spleen is not palpable.
Okay,
Left lobe of liver is also palpable.
fine, good.
What is the tone of the muscles?
Normal, sir. Normal, sir. Look.
So do you think it's a Downs? The most important characteristic is a hypotonia, and that is missing.
So how do you
Hypotonia.
demonstrate hypotonia in this
One
baby?
is posture. Posture of the baby is lying like flat on the bed. Not significantly low.
So you mentioned there is hypotonia. So what did you look for? So see, posture is not like sacrosanct, you know. Even a child with a normal tone in sleep will have a frog-like posture, right? So posture is not. So what are the other things you should look for?
What is tone really? What is
resistance
tone?
Resistance to movement. So he is resisting to my hand.
And what is active tone and passive tone?
So passive is when we demonstrate tone by passively moving the joint, and active is like when we put the patient on some postural maneuvers. Then what the response child shows, that is active tone. Like on ventral suspension, how does the child behave? This could be an active tone.
So what signs will you look for hypotonia?
Okay, the scarf.
What
sign,
is scarf
vertical
sign?
Angle. While when we try to put by fixing the shoulder, we'll try to flex the elbow. If it is crossing this midline, then it is hypotonia. In this case, it's not crossing the midline. It is at the midline.
Come to
And
the forearm.
Flexing the wrist and trying to touch the thumb to the forearm.
Okay.
Then
Popliteal angle.
Popliteal angle.
And then you hold the baby vertically and whether the baby is slipping through your hands, right?
And see whether the knee can be hyperextended. Okay, normally we are only up to straight line, but can you even hyperextend? No.
And then typically, this is of course a newborn, so here it's possible, but you have a 6-7 month old Downs and you can still touch the toes to the head. You know, so that is a classic sign of hypotonia.
If this is hypotonia, is it central, peripheral or nutritional?
Okay, in central there will be
Peripheral?
No, she's saying in central,
power will be not affected.
so here it is.
Power is not affected. Is against the gravity.
Central I thought is spastic. How can central be hypotonic? Central is spasticity, no? Peripheral is hypotonia.
Pyramidal
Upper
versus
motor,
extra.
upper motor and lower motor. Ask an undergraduate, he will say spasticity, upper motor, lower motor.
So
how can it
pyramidal
be
versus-
central?
Cerebellar.
Tone is motor system, no? So it's pyramidal. Correct? Upper pyramid, upper motor, no? How can it be? Tone is motor, no? Motor is upper, no? Upper pyramidal. It has to be spasticity. How can it be hypotonia? Hypotonia is peripheral. You agree with me? Hypotonia can't be central.
So extrapyramidal lesions involved.
Cerebellar lesions.
Cerebellar, yes. So is there a cerebellar hypotonia? Yes, that's central, agreed. So do you see nystagmus or any tremors or anything? So can it be cortical hypotonia? That's the question. Cortical is increased tone, but could cortical be hypotonia? And the answer is yes, because the tracts which connect the cortex to the lower centers are affected, which means a central hypotonia is a generalized brain affection. And that is what is happening here. But why not peripheral? Every hypotonia is peripheral till proved otherwise, or nutritional. Why not peripheral?
For peripheral hypotonia, power also will be
Excellent.
less.
Power, reflexes, etc. Power is normal, so it has to be central. Why not nutritional? Power is normal, tone is low, and severe malnutrition. Why not nutritional? So here you would say that there is an evidence of a brain disease, so it could be combined central plus nutritional, but not isolated nutrition. That is what.
So we were discussing oligo versus poly. So Dr. Anjali has said that if they have duodenal atresia, then they can have poly also. Okay.
Flat occiput, mongoloid and depressed nasal bridge, oral cavity, chest is normal, skull spine was normal, genitals are normal. I thought Sandel gap is present.
How do you test hypotonia of the abdominal muscles? I don't know. I can test like this, no? Abdomen what? You move the abdomen. How do you test the abdominal? No, she's right. How do you test it?
Protrude. Like it was looking distended, but was not actually distended.
Looking
Flabby
distended.
abdomen. Okay. Flabby abdomen, distended, flabby. Muscles are flabby. Okay, yeah.
Icterus was present. It was present in the eyes and like all over the body. No pallor, clubbing, cyanosis, edema, lymphadenopathy. Even I got a liver which was 2.5 centimeter palpable below the subcostal margin with a smooth surface, rounded regular margin. On percussion dull note only over the liver, otherwise it was tympanic all over the abdo. CNS, I thought hypotonia was present. Activity was, the child was good, reflexes 2+. I thought Sandel gap was present.
Even I thought.
So 1 month, 8 days old female child with gradually progressive jaundice who is anthropometrically like failure to thrive, immunized till date with phenotypic features suggestive of Downs with icterus and non-tender hepatomegaly is most probably a case of neonatal cholestasis with Down syndrome. So the cause for the cholestasis,
So you have to give a differential. So what are your possibilities?
can be related to Downs like hypothyroidism because in like afterwards when we investigated, so
hypothyroidism, I don't know whether it can lead to such deep jaundice, by itself. It contributes to prolonged physiological jaundice and things like that, but I don't think it can cause such deep jaundice.
I think the Downs don't have a clinical hypothyroidism, they have a biochemical hypothyroidism. So hypothyroid should be short and having abnormal faces, that is not there. So that is unlikely. My question is, Downs is an abnormality, right? Structural. There is a heart problem, they said something, whatever. Therefore, why not talk it as a biliary atresia only? Structural problem, no? Heart has structural problem. So, you get my point? One malformation, multiple malformations. That's the rule. So, Downs is malformation.
So is biliary atresia a chromosomal disorder? So what kind of a disorder is it?
So is biliary atresia a structural malformation? No, it is an fetally acquired infection. And that's why some go with neonatal hepatitis, some go with biliary atresia. Ultimately, they become hepatobiliary because nobody in the first 3 months has any of those. They develop in the second or third trimester and then progress one way or the other. So that is not. But they have many other things. Is the paucity of biliary system? There's something in the heart. Something in the heart is also down. But all these are probabilities. So you're right to say that this is likely, but then you said PFIC also. Okay. So the question is, tell us whether it's really an intrahepatic cholestasis or extrahepatic. At least we should be able to differentiate the two. Then in each, whatever the cause. What do you think? It's an intrahepatic or extrahepatic?
I think it is intrahepatic.
Why? You're right. Why?
I thought of clay-colored stools first, but that's
No,
not
so
an
the
absolute
baby is not thriving. Na? That is a important reason why it could be intrahepatic. Okay.
So investigations. So the total bili. So the first time the child was investigated. So on 7th of November, total bili was 4.56. Direct bilirubin was 3.30, which increased to 22 and 12.2 on 8th, and which progressively increased to 22.9. And direct bili was 11 on 10th of November. OTPT were raised 142 and 110. PTINR was normal. Serum ammonia was raised, it's 104. CBC was within normal limit. This is the chromosomal, the karyotyping was sent, so we got the report. So it is suggestive of trisomy 21.
Fine. So how do you interpret the reports?
And so this AFP levels were sent, which were quite high, 17,100.
AFP levels.
Yeah.
So what does that indicate?
AFP levels this high would suggest of some tumors, but the consistency on palpation of the liver was soft. So, and on USG also we didn't get any lesion on the liver. Adenomyosis was there.
Will a hepatic tumor lead to jaundice?
Can lead if it causes obstruction of the biliary system, the bile ducts and all.
So only if there is a obstructive thing, but hepatic tumor
Per se
doesn't cause
won't. Later
obstruction.
stages
So otherwise
will
it's a
lead.
localized disease,
Yeah.
right? So it doesn't cause jaundice. Okay. So you are still awaiting any
Yeah.
further tests?
Under evaluation. So,
Okay.
yeah.
I think both the presenters have taken extra efforts to do all that. Okay, they have photographs, they have all that. So, very well. I'm sure it has spent some extra time.
She's quite junior, so.
Very good.
Very
As a
good.
junior, you stand there. Very good, isn't it? Even I have a palpitation. Okay, and you are so confident, so excellent. Yeah.
Chalo. So I think good. So we stop the class today here. We don't have a final diagnosis in both the cases, which we hope to hear from next Thursday from them. So thank you all our friends who are watching online, students as well as online faculty. And we meet once again on next Thursday at 6 p.m. Thank you.